Hi, this is Christine Mealy, Nurse Diabetes Educator at Littleton Regional Healthcare, and I'm going to talk to you today about medications for type 2 diabetes and what you need to know as a nurse at Littleton Regional Healthcare. So with diabetes medications for type 2 diabetes, what do you need to know? Well, today we're going to talk about the main action of the different categories of type 2 diabetes medications. We're going to talk about some of the major side effects, and we're also going to talk about some of the nursing clinical considerations of each category of medication. So what is type 2 diabetes? Type 2 diabetes is a complex metabolic disorder. It creates insulin resistance, and it also creates an insulin deficiency. You do have social, behavioral, and environmental risk factors that can play a huge part for a person developing type 2 diabetes, as well as a huge genetic component to somebody developing type 2 diabetes. Some of your risk factors will include a poor diet, lack of exercise, or if you grew up in a family where this was the norm, having a poor diet and a sedentary lifestyle, that puts you at a greater risk of developing type 2 diabetes. So what is the role of the pancreas? The pancreas has some very important endocrine functions. Your beta cells produce insulin, and they also produce amylin. These are both hormones. The insulin is probably what you're most familiar with. It's an anabolic hormone, and it helps insulin store glucose as glycogen in the muscle and liver. It is also secreted in response to an elevated blood glucose. And it also halts the breakdown of glycogen from the liver, and it increases protein synthesis, fat storage, and as you all probably know, it is a powerful hypoglycemic. What you may not be so familiar with is an amylin, and that is secreted in a specific ratio with insulin, and it causes people to feel full. It also slows gastric emptying, which makes people feel fuller longer. And it also lowers post-meal glucose response. And it's very important hormone because type 2 diabetics make much lesser amounts than the typical person who doesn't have diabetes, and a type 1 diabetic makes none. The ominous octet and why you should know this. This is a very, very interesting organization of some of the things that happen to people with type 2 diabetes. And this comes from the 2008 Banting Lecture from American Diabetes Association. And it's from a physician who has actually got a very prestigious award. His name is Dr. DeFranzo. And he identified 8 different things that happen to people or deficiencies with type 2 diabetes. So people with type 2 diabetes have an increased liver production of glucose. They also have an increased free fatty acid circulation. They have an increased alpha cell secretion of glucagon, and they also have an increased glucose reabsorption from the kidney. They also have a decreased insulin amylin secretion. They have a decreased muscle absorption of glucose. They have decreased gut hormones, and they actually have a decreased neurotransmitter function from the brain, which affects their appetite control. And this is very important information and organization of this information because it's actually driving new therapies and new medications to treat type 2 diabetes. So now we're going to go into the medication portion of the presentation. And as we're going through the slides, I'd like you to start thinking about what would be the ideal diabetes medication. So what I would be looking for a medication that caused no hypoglycemia, no weight gain, it was affordable, it lowered cardiovascular risk, and most people could tolerate it. On this slide, I'd like you to notice all the different types of medications that focus on different parts of the body to try to treat high blood sugar. The easiest way to organize the medications and to learn them is to put them in by action or classes of type 2 oral medications. So what we're going to discuss today is the suppressors, squirters, satiators, sensitizers, glucoretics, circadian switchers, and the slowers. And what I'm really going to focus on is giving you exposure to all of the medications that are available today, but I really don't want to spend a great deal of time discussing the less familiar medications. I really wanted to try to focus this presentation on medications that you would most likely see at the bedside at Littleton Regional Healthcare. But you should know that these other medications are out there and what they do. And if you do have further questions, that you should either check your resources or ask your pharmacist. The first medication we're going to start with today is the suppressor. It's also in the, and that's the action of the biguanides. And your metformin is in your biguanides class, and you're probably very familiar with it. It goes by the name of glucophage as well. And most people who develop type 2 diabetes, this tends to be the first medication that providers will prescribe to type 2 diabetes patients. And the action, what it actually does is metformin suppresses the release of glycogen from the liver. It's the glycogen stopper. And a lot of people don't realize that your liver plays a very big role in hyperglycemia. Your liver stores sugar in the form of glycogen, and it releases it throughout the day. And metformin basically tells the liver to be quiet, and that helps to lower the fasting blood glucose. And a lot of times people who have an earlier diagnosis with diabetes, they can go on this medication, and it really helps them dramatically and helps normalize their blood sugars. But diabetes does tend to be a progressive disease, so sometimes the metformin after a period of time isn't enough to maintain a normal glycemic level in their body, so sometimes they need additional medications or even insulin. Metformin typically people will be started out with 500 milligrams BID, and it can go up to a max of 2,500 milligrams daily. A lot of research has been completed on metformin, and a lot of providers will not go greater than 2,000 milligrams daily because through the research they found that 2,500 milligrams a day versus 2,000 milligrams per day didn't really have that great of effect. So a lot of providers will not go greater than 2,000 milligrams daily. So you also have an extended release formula of metformin, which tends to be very helpful for patients who are experience some of the side effects of metformin. And the greatest side effect for metformin tends to be a GI upset or diarrhea. A lot of people will complain of crampiness, urgency with the diarrhea, which is very, very inconvenient. And that is also a huge issue on compliance with patients actually taking their medications. In the outpatient setting, I've experienced several patients that were refusing to take their metformin because they were working and they were having urgency with diarrhea, which obviously is not going to be conducive with a job that requires you to be away from a bathroom. So ways around that is you can have the patients actually take their medication mid-meal. And a lot of times that will help with the GI effects, and usually if that doesn't work, the extended release formula for some reason tends to make have fewer GI side effects. So those are options that you could suggest to your patient, that if they are experiencing a lot of the GI effects with the metformin, is to take it mid-meal, or to ask their provider if they can go on the extended release formula. Metformin is highly effective. It tends to reduce the A1C 1 to 2%. And just as a refresher on what the A1C is a blood value that we do, a blood test that we do every 3 months for somebody with type 2 diabetes or type 1 diabetes as well. And what it does is it gives us an average of what that patient's blood glucose level has been for the last 2 to 3 months. And it gives us a very big picture of how well the diabetes medications are working, or how well the patient has been managing their diabetes as well. Sometimes just the information from the personal glucometer can be misleading, because if a patient is only testing once a week or testing once a day, we may not be getting the full big picture. Metformin tends to reduce the A1C 1 to 2%, which is a very big deal. For every 1% that you decrease your A1C, you decrease somebody's risk of a heart attack or stroke by almost 37%. So it's a huge, huge deal. As nurses, we may not always know that there is a huge effect from diabetes to the cardiovascular system. Diabetes damages all the vascular system. So having the reduction of the A1C so dramatic of 1 to 2%, it's a really big deal. Side effects of metformin, we pretty much talked about the big ones, diarrhea and abdominal discomfort, but it also can cause lactic acidosis if improperly prescribed, especially for somebody who has decreased renal function. Metformin can also cause a moderate decrease in the bad cholesterol and triglycerides, which are typically elevated in somebody who has a type 2 diabetes diagnosis. A great thing about metformin, it does not tend to cause weight gain, and some people actually experience a modest weight loss, which is huge for people with type 2 diabetes because they tend to be overweight or obese. We do need to watch for a vitamin B12 deficiency that should be tested typically 6 months after use. And we also want to be cautious with IV contrast dye studies. Typically, metformin is held for 48 hours after an IV contrast testing. And also, we should be testing for kidney function prior to restarting the metformin as well. Additional nursing considerations with metformin or glucophage would be lactic acidosis, which could be part of sepsis or kidney impairment, a creatinine greater than 1.4 in females or greater than 1.5 in males, liver disease, alcohol abuse, over 80 years old, risk of acidosis. We discussed already the IV study. Considerations. And another piece that's interesting is a patient who has congestive heart failure and they are on medications. In the United States, it's considered acceptable and safe to prescribe and take metformin if you are on heart failure medications and you're stable. But during an acute CHF episode, metformin is recommended to be temporarily held. So you may want to talk to your provider if you do notice that the metformin is still being prescribed and you have a patient in active CHF. So let's rate metformin. Based on some of the questions we talked about at the beginning of the presentation and some of our things that we would call for our ideal medication for diabetes, let's rate metformin. Does it cause hypoglycemia? No, it does not. Does it cause weight gain? Typically does not cause weight gain. Is it affordable? Yes, it is. Does it lower our cardiovascular risk? Well, with a reduction in A1C of 1 to 2%, absolutely. Can most people tolerate it? Yes, most people can tolerate it. Most of the patients that I do see at Littleton Regional Health Care in the outpatient setting do not have issues with metformin. They tend to do very, very well on this medication. And it is pretty much the initial medication that most providers choose for the first medication therapy for patients. The next group of medications that we're going to discuss are the sulfonylureas. And basically what they do is they tell the pancreas to squirt insulin all day long. So what kind of patient would you think might benefit the most from this? A leaner type 2 patient with type 2 diabetes. Although you will see a lot of patients who are not lean and have type 2 diabetes on these medications as well. So our sulfonylureas are our squirters. Their action, as we already discussed, is to increase the insulin secretion from the pancreas. They tend to decrease the fasting blood glucose by about 60 to 70 points. And it reduces the A1C typically by 1 to 2%. So it's a great therapeutic medication for most people. But the thing with the sulfonylureas is after 5 or more years of taking them, due to the natural history of type 2 diabetes, which tends to be a progressive disease, which a lot of people aren't quite aware of the fact that after a while that they may need additional medications. The patient may need something else in addition to a sulfonylurea, and they may actually need insulin altogether. With the sulfonylureas, you have your first generation and your second generation sulfonylureas. With your first generation medication, you'd see the Dibonese, Tolinase, Orinase. I have not seen very many patients on these medications in the outpatient setting, and I don't believe seeing anybody when I was working in the ICU as well on any of these first generation medications. We ought to use them with caution in the elderly and those with renal disease issues, and they can also cause a flushing reaction with alcohol. The second generation sulfonylureas are typically what I've been seeing in the outpatient setting here at Littleton Regional Healthcare. You see your glyburide, your glipizides, and your glimepiride. Your trade names, as you can see on the screen, are your diabeta, micronase, glucotrol, glucotrol XL, and Amaryl. These are the typical medications that you're going to see most type 2 diabetes patients are on. Some of your providers are actually prescribing these as their first medication for their patients with diabetes. With your sulfonylureas, there is a risk of hypoglycemia because if you have a pancreas that's squirting insulin all day and you have a patient who has missed a meal, missed a snack, they may actually experience a low blood sugar. Another side effect of a sulfonylurea is possible weight gain. And also, too, sulfonylureas are cleared by the kidney, so we must use them with caution in patients that have kidney problems. And it is very inexpensive medication, so you will have a lot of providers do like to put their patients on this medication if they are having financial issues, because they are effective and they are affordable. The next group of medications we're going to talk about are the secretagogues, the meglitinides. And this basically tells the pancreas to squirt insulin with meals. And it just senses that there's a rise in the glucose levels. And this basically targets the post-meal hyperglycemia. So with the meglitinides, again, the action is it stimulates insulin secretion when the glucose is present. Your brand names are your Prandin and your Starlix. I have seen some patients in the inpatient and outpatient setting at Littleton Regional Healthcare on these medications. Things to be aware of that it is metabolized by the liver and mostly excreted in the feces, although some is secreted renally. You also have an efficacy of decreasing your glucose by about 60 to 70 points, and it reduces the A1C of roughly 1 to 2%. So let's look at the side effects of the meglitinides. Hypoglycemia. It's a little bit less than with the sulfonylureas if the patient has a variable eating schedule because it's most effective when glucose is present. Minimal weight gain with the meglitinides. No significant effect on the plasma lipid levels, unfortunately, but it is safe at higher levels of a serum creatinine than with the sulfonylureas. So let's rate the squirters. And how would you rate them? Well, do they cause hypoglycemia? Yes, they do. Weight gain? Unfortunately, yes. Affordable? Yes, they are. Lower cardiovascular risk? Not really. Can most tolerate and use? Yes and no. If you've got somebody who's going to be eating on a regular basis, not skipping meals, definitely can tolerate. But if you have somebody who maybe forget or gets too busy and does not take a meal or a snack, they do run a high risk of having those low blood sugars. The next group of medications we're going to look at are the amylin mimetics, incretin mimetics, and the DPP4 inhibitors. And these are all focusing on the gut hormones. And as you probably remember from the earlier slides, with people with type 2 diabetes, their gut hormones tend to be deficient. So these newer therapies are focusing on the gut hormones. The first medication we're going to talk about in this group is Simlin. And I love the name of the medication because Simlin basically is a synthetic form of amylin. So if you look at the name Simlin, amylin, it's a lot easier to remember. And what amylin is, if we remember from the previous slides, is a very powerful gut hormone. And most people with type 2 diabetes are deficient in amylin. And amylin is a very important hormone because it slows gastric emptying, it helps us to feel full, it helps us to feel full longer, and it also helps to control our after-meal blood glucose levels. So it's a very, very important hormone. So this is one of the newer therapies that you're going to see more and more often because it is effective. Some of the side effects, unfortunately, though, it can cause low blood sugar, nausea, loss of appetite, and redness and swelling at the injection site. It is contraindicated in patients with gastroparesis or patients who have hypoglycemia unawareness. Patient education is very important with this medication, so I do recommend, again, if you do have a patient who is on this medication and they haven't had any outpatient teaching, that they should seek that out. So let's rate Simlin. How would you rate it? Does it cause hypoglycemia? Well, not directly, but yes, it can. And what it does is it causes the pancreas to squirt more insulin out. So we do have to be aware that that can be a potential side effect with Simlin. Does it cause weight gain? Typically, no. Affordable? No. And unfortunately, that's one of the greatest barriers you're going to find with some of the newer therapies is that they're extremely expensive. Does it lower cardiovascular risk? No. And can most people tolerate or use it? Not really. On this side, we're going to look at GLP-1, and GLP-1 is a very important gut hormone. And as we talked about earlier, people with type 2 diabetes are deficient in their gut hormones. And you can see how important this one hormone, GLP-1, is in controlling blood sugars. And unfortunately, GLP-1 can be quickly degraded in the gut by an enzyme called DPP4. So you're going to see in some of the next few slides, when we're discussing some of the medications, they're going to really be focusing on the GLP-1 effect. So now we're going to look at the incretin mimetics, and what they're doing is they're mimicking the action of the hormone GLP-1, and what this does is allows insulin to work more effectively in the body. Now these medications are injections. They are not insulin, but they're usually taken in conjunction with other medications, including insulin. Byetta and Bydureon and Victoza are your trade names. Your Byetta is injected twice a day. Victoza is injected once a day. And the Bydureon is a newer formulation that is just injected once a week. And what they appear to do is they delay the movement of food from the stomach into the small intestine. As a result, people feel full faster and longer, so they tend to eat less, which usually leads to weight loss, which is a very big deal with type 2 diabetes because our body fat tends to make us insulin resistant. Taking a closer look at Bydureon, this is a once-a-week dosing. This is a newer formulation. I have not seen anybody on this medication yet, but I do anticipate that more and more people will be on these type of medications as they become more affordable. The challenge with the Bydureon, though, is that it is a powdered form, so it has to be mixed and injected. So that's a little bit more complicated. So there is a patient education portion that needs to be addressed with this new medication. The next medication for the incretins would be the Victoza. This is a little bit more familiar because they do some advertising on the television. So you might see this a little bit more often if you see it in the inpatient setting. It does tend to lower the A1C by 1% and the body weight by 5.5 pounds, which we talked about previously is quite a big deal with people with type 2 diabetes. Much more attractive because it does come in a pen with preset dosing. Black box warning, contraindication with thyroid tumor history, and you want to notify your physician if you have a hoarseness or any lumps. Some nursing considerations with Victoza and Byetta: you want to store the pens in the refrigerator and toss them after 30 days. They are sub-Q injection in the abdomen, thigh, or upper arm. I do have some great handouts to provide to patients which will show appropriate injection sites. Again, I do suggest any patient who you come across that is on these medications and have not had outpatient training on them, that you do refer them to the outpatient diabetes education program. To prevent hypoglycemia, you're probably going to want to reduce your sulfonylurea or insulin dose when starting. Typical side effects include nausea and diarrhea. There is a pancreatitis warning with these medications, so the patient needs to be instructed to report any abdominal pain or vomiting. And we don't want to use these medications. They are contraindicated with gastroparesis or severe renal disease. So how would you rate the incretin mimetics? Do they cause hypoglycemia? No. Cause weight gain? No. They're actually typically a weight loss. Affordable? Absolutely not. But we're hoping that's going to change in the near future. Lowers cardiovascular risk? Nope, not directly. Can most tolerate? Yes, they can, but some people will have some GI effects. So the next group we're going to look at are the DPP-4 inhibitors. They're considered the incretin enhancers. And what they do is they help stop the degradation of the gut hormones by an enzyme called DPP-4. And those are your Januvia, your Tridenta, your Onglitazar, your Nesina. They also help increase the insulin release with meals, suppress the glucagon. They tend to not cause weight gain or hypoglycemia. Some of the side effects are headache, runny nose, sore throat. Also another one you have to watch for pancreatitis with. So let's rate the DPP-4 inhibitors. Cause hypoglycemia? Nope. Weight gain? No. Affordable? No. Another one that's very expensive, but we're hoping that's going to change again with the Affordable Care Act. Lowers cardiovascular risk? No. Can most tolerate? No. The next group of medications we're going to look at are the insulin sensitizers. These are your TZDs. Your brand names are Avandia and Actos. And these are indicated for patients that are highly insulin resistant or have metabolic syndrome. These medications are highly regulated by the FDA because of some significant side effects. So this is where you have the campaign against these medications. Avandia is actually FDA restricted. No new patients can start on this medication. They are offered only through mail order. They are not in pharmacies. They are associated with increased risk of an MI. Your restrictions are also on the medications that include Avandia with other medications such as Avandamet and Avandaril. The other medication is Actos. It does have a warning for bladder cancer risk. The risk is increased with a larger dose and duration. France has pulled Actos off the market completely. Germany has restricted their access to this medication. The FDA does recommend that we do not use this with patients with an active bladder cancer, and you can use with caution in patients with history of prior history of bladder cancer. The benefits of the blood sugar control should be weighed against the unknown risk for cancer reoccurrence. Patients are instructed to report symptoms of bladder cancer, which could include blood or red color in urine, urgent need to urinate or pain while urinating, pain in the back or lower abdomen. The next group of medications we're going to look at are the SGLT2 inhibitors, and these are a glucoretic. They actually decrease the renal reabsorption in the proximal tubule of the kidneys, which is very interesting. If we go back to the ominous octet, you'll see that people who have type 2 diabetes tend to have an increased renal reabsorption of glucose. So this is one of those new medications that is working on some of the problems that are typical with people who have type 2 diabetes. Your typical dosing is 100 to 300 milligrams once daily. AC before the first meal, and your efficacy tends to be a weight loss of 1 to 3 pounds. The A1C tends to be reduced by 3/4 to 1%. I have not seen very many people on this medication. It is very new. Lots and lots of advertisements sent to the diabetes education program, giving information and pamphlets. So you may be seeing more of this medication in the near future. Some of the nursing considerations with these medications, side effects. You might have hypotension, UTI, increased urination, yeast infections. There is some question out there whether or not it actually improves beta cell function, which would be wonderful. Reverses glucose toxicity, increases the liver sensitivity to insulin, and it also decreases gluconeogenesis. The next group of medications we're going to look at are the circadian switches. This is the dopamine receptor agonist, bromocriptine mesylate QR, or quick release. And the action of this medication is it actually increases the dopamine levels in the brain. And this in turn decreases insulin resistance. It also tends to decrease dyslipidemia. And it also doesn't cause weight gain. So with your circadian switches, what happens when you have your increased dopamine levels? You have the decreased insulin resistance, you have decreased hepatic glucose output, you have decreased lipolysis and lipogenesis, and you have decreased vascular pathology, which is a huge deal with people with type 2 diabetes, or type 1 diabetes, that is too, which is the cardiovascular effects of the diabetes. You also will have an increased insulin sensitivity and an increased glucose tolerance. So on your dopamine agonists, your circadian resetters or switchers, you have an increased morning dopamine level. The brand name is called Cycloset. You want to give that to your patient within 2 hours of waking before food. It does give a moderate reduction in the A1C of 0.6 to 0.9%, does reduce death from cardiovascular events, which is a very big deal. Some of your unfortunate side effects are nausea, vomiting, headaches, and fatigue. You do need to watch for syncope. So how would you rate Cycloset? Does it cause hypoglycemia? Nope. Does it cause weight gain? Nope. Affordable? Not really. Does it lower cardiovascular risk? Yes, it does. That's the biggie. Can most tolerate it or use it? Not really, no. The jury is still out on that one. So the next group of medications we're going to look at are the glucoside inhibitors. And what they do is they basically prevent the degradation of carbohydrates in the GI tract. So these medications are the acarbose, the miglatol or glycet, Precose. Their action is called the slower. And these tend to target the post-meal blood glucose and have a minimal systemic absorption. So with Precose, what we're doing is we're blocking the enzymes that digest the starches in the small intestine. So what can happen with something like that is you can end up with a lot of flatulence or abdominal discomfort. So these medications are definitely contraindicated for patients who do have IBS or cirrhosis. They do have a moderate efficacy with their A1C of 0.5 to 1%, and they do tend to decrease the post-meal glucose level 40 to 50 points. There are some special considerations with Precose, is that in the case of hypoglycemia, it must be treated with glucose tabs or milk. Other starches are blocked by this medication. So how would you rate Precose? Does it cause hypoglycemia? No. Weight gain? Yes. Affordable? No. Does it lower cardiovascular risk? Yes, it does. Can most people tolerate or use? Not really. With the GI side effects, a lot of people will be turned off from this medication. So on this next slide, what we're going to talk about are the insulin action profiles of the most common insulins that you're going to be seeing in our community. This is not all of the insulins that are available out there, but these are the big players. So what we need to do is we need to look at the different actions of insulin. You have some are a bolus and some are basal, and some of them are the bolus and basal combined in one medication. So what you have is you have the Novolog, which typically is what we use here at the bedside at Littleton Regional Healthcare. And you also have Humalog, and these are your rapid acting analog insulins. And these take effect within 5 to 15 minutes. They tend to peak in 30 to 90 minutes, and they stick around for about a little less than 5 hours. So these are the medications that are designed to cover the patient's food intake. So it's important as a nurse to understand how quickly some of these take effect. And then there's also the short acting, which is very similar to the rapid acting, but that onset for these for that insulin is 30 to 60 minutes, and that peaks in 2 to 3 hours, and it can still be sticking around for 5 to 8 hours. So if you have a patient that is still on regular insulin and you're going to give them a meal, you don't really want to give them that regular insulin as you're serving the tray. You really want to try to give it 30 minutes prior to the meal. That way it will have a better effect for the patient's blood sugar. Whereas with the rapid acting, you want to give that medication right before you hand the patient the tray, basically 5 to 10 minutes before the patient starts their meal. So that's got to be a little bit trickier with the timing sometimes when you're on the floor, to keep that in mind. If the patient has not ordered their meal yet and you're giving them their rapid acting insulin, they may experience a low blood sugar if they delay their meal. Then you want to look at the basal insulins, and those are your intermediate or your long-acting insulins. You do have quite a few patients in the community that are still on NPH, and that's your cloudy insulin. And what that does is that provides a insulin that's available to the patient throughout a certain period of time. Typically, it sticks around for 10 to 16 hours. The onset of NPH is usually 2 to 4 hours. It peaks in anywhere between 4 to 10 hours. So with the NPH, it can be a little bit trickier to make sure that the patient does not experience a low blood sugar. So it's very important if you have a patient that is on NPH that they get regular snacks and that they're eating their meals at a specific time interval to make sure that they don't experience a low blood sugar. And then you have your long-acting insulins, which we do use Levemir and Lantus. Most of the patients I've seen on the inpatient at Littleton Regional Healthcare are on the Levemir, but a lot of your patients on the outpatient are on Lantus. And those typically have an onset of 3 to 8 hours for the Levemir, 2 to 4 hours for your Lantus. And what's really nice about these newer long-acting insulins is that they tend not to have a peak. So your patients are at a reduced risk of hypoglycemia with these long-acting insulins. They do require regular meals and regular snacks, but with the NPH, they sometimes often you've seen patients that will have severe lows because they didn't take a meal and the NPH had peaked at an unopportune time for them. So with your Levemir, your typical effective duration is 6 to 24 hours. Your Lantus is 20 to 24 hours. And then you also have some insulins that are putting the bolus and basal together, and that's your intermediate insulin. It could be mixed with rapid insulin. You can have your Novolog 7030, your Humalog mix, 75-25 or 50-50. And those have dual peaks, so it's very important to be aware of the peaks of these insulins so that you can make sure that your patient is having adequate food intake, snacks, and that they're aware of what a hypoglycemic incident would feel like. Your typical effective duration for these bolus and basal together are 10 to 16 hours. And then you also have your combination of NPH and regular, which can be a 70-30 or a 50-50. Onset is 30 to 60 minutes. Your peak tends to be a dual peak as well, and your effective duration is typically 10 to 16 hours. So if you look on the bottom of the slide, you'll see what the bolus insulin lowers the after meal glucose level, and we can tell if we've got an appropriate dose because it's going to be reflected in the post-meal blood glucose. And typically we check 2 hours after a meal, and that lets us know whether or not the dose that we gave them for the meal is appropriate. And then your basal insulin controls the glucose between the meals and at bedtime. And we can tell if we've got the right dose if our morning fasting blood glucose is within range. And the typical range for the recommendation for American Diabetes Association is we're looking for an AM fasting blood glucose of between 70 and 130. And American Diabetes Association recommends for a 2-hour postprandial or 2 hours post-meal blood sugar to be less than 180. Some of the insulin side effects can include hypoglycemia and weight gain. So it's very important that if you do have a patient that is on insulin, and if they're going home on insulin, that they are able to recognize the signs and symptoms of hypoglycemia and how to treat it. We do have a diabetes action plan, which is on the next slide, and I will start looking at that next. So what you're looking at on this slide is the Diabetes Action Plan at Littleton Regional Healthcare. And what I really want to focus in on this slide is how to treat a low blood sugar. And so this is something that I try to teach patients before they're discharged and they have either insulin or they're on a medication that can cause low blood sugar. And this just gives them a very effective tool in training on how to treat low blood sugar safely. So the rule is that if somebody's experiencing any of the symptoms of hypoglycemia, the first thing we want them to do is to check their blood sugar, because some of the symptoms of hypoglycemia can mimic hyperglycemia, or they could have some other condition going on. So we want to make sure that what we're actually treating a low blood sugar and not something else. So the first rule is to test. So if the blood sugar is below 70, we want to take in a very fast-acting carbohydrate, and that usually includes can include 4 glucose tablets or 4 ounces of juice. A lot of patients on the outpatient setting have glucose tablets, and a lot of them are under the impression that they're only supposed to take 1. The recommendation is actually to take 4. So you want to take 4 of those, or you can take 4 ounces of orange juice, apple juice, a cup of milk is equivalent. I've noticed quite a few patients will say, well, I'll eat a candy bar, I'll eat a cookie, I'll have a piece of bread. Well, those will eventually raise your blood sugar, but we want something faster than that. So what we want is the glucose tablets is the #1 recommendation, juice, milk, even some hard lifesaver candies. The fruit ones work very quickly as well. We want to wait 15 minutes after we've treated the blood sugar, and then we want to retest again. If it is above 70, we want to have a small snack, or if it's mealtime, have our meal. And that's designed so that we don't trend back down into the hypoglycemia zone again. If the blood sugar is still below 70 after we've treated it, we want to treat it again. And a lot of patients don't realize that. They just will treat it once and then they'll go on about on their way. So it's very important that they know it's okay to treat it more than once if they're still below 70. And you can see on the action plan here as well, there's some other tips on how to make sure that you have an accurate reading and what to do if you have hyperglycemia. The recommendation from the action plan is if you have 2 consecutive readings above 240 is that you want to reach out to your physician, because might be something else going on. And this concludes the slides, and I hope you enjoyed this. There is a small quiz after this, but it is focused on LRH specific needs. So I hope you'll enjoy that and have a great day.